And this concludes our main session. And here's the opportunity for you to participate and to ask your questions of our presenters. Our presenters will come to the front of the auditorium and we'll take your questions. We have individuals on either side of the auditorium with mics.
Thanks. My question is, are you eligible for the DIEP surgery if you've had laparoscopic surgery such as gallbladder or ovary removal?
Siba?
Is my mic on? Yes.
It is.
Okay. Yes, you are. So typically, those small scars do not affect the blood supply to the abdomen. However, to be safe, whenever there's any scars on the abdomen or the belly, we typically get a CT scan, like we discussed, just to make sure those little vessels are available.
Any questions from the online?
Yes, there's lots of questions online. One question that I think might be, it's a challenging one for the surgeons, but I'm going to ask it anyway. There are several people who have talked about delayed reconstruction, and in the context of COVID, some people talking about living in remote communities, the wait times. So could you perhaps just comment on what wait times are looking like for delayed reconstruction?
So it sort of depends. It depends on sort of what resources are available for the surgeon that you're seeing. Typically speaking, we do try to get the immediate reconstructions done on a priority basis if they need to get their cancer out. However, that being said, we are certainly doing delayed reconstruction. Implant-based cases require less resources, so shorter operative time, which means that you may potentially get in a little bit sooner than if you're having a delayed flat-based reconstruction, which requires typically an entire operative day. So it sort of depends on the surgeon that you're seeing. But we're certainly doing delayed reconstruction for sure.
The only thing I might add to that is, unfortunately, COVID did prevent us from getting a lot of patients in the sense of doing immediate reconstruction. So we did have to delay the reconstruction. Having said that, yes, the wait times really depend on the center that you're going to. The other important thing to talk about is access. I think access is important, and as mentioned in the question is whether or not there's access up north to things like certain types of reconstruction, such as maybe using your own tissue. I think it's important that, we cast a wide net in terms of who are the referring doctors that are actually available that are able to do that. But most certainly we do a lot of delayed reconstruction.
Yeah, on a positive note, 25 or 30 years ago, so much of the breast reconstruction that was done in Canada, or certainly in Ontario, was done in a very few centers. So it's very, very difficult for people to access breast reconstruction, especially immediate reconstruction, where they were having their cancer care somewhere and needed a reconstructive surgeon to be at that location to get their reconstruction done. The good news is that over the last couple decades, we've really populated excellent reconstructive surgeons in multiple communities all over the place. Academic community centers, rural and urban centers. So there's still a lot of work to do, but there, I think, are fairly good, skilled, talented reconstructive surgeons in many, many small communities in Ontario today. Hospital resources are a different problem, and it's just a significant ongoing challenge. And the problem is that for women who have opted or find themselves in a position for delayed breast reconstruction, unfortunately, they're lower on a priority scale than an immediate reconstruction case that has now an active case of breast cancer that is very timely in terms of having to get into the operating room and have their treatment done. And so that sort of sends the delayed reconstruction patient a little bit further down the list. But in my view, advocacy, and that's, the way to put these things at the top of the agenda. Please, at the back.
Is it better to have a delayed reconstruction, to have a mastectomy, a double mastectomy, if it's a delayed reconstruction?
Okay, Dr.
Cosmetically speaking.
Tulin, would you like to address that?
I guess I'll defer to the plastic surgery colleagues about the cosmesis aspect, but in terms of the oncologic indications, generally we would look at a patient's risk, and if they did have an elevated lifetime risk, then there may be a benefit to removing the other breast. But generally we focus on the side that's affected. But I think if you want to comment, Siva or John, about the cosmesis of doing one side or the other.
I don't think reconstructing a single breast versus a double breast they're equal. It wouldn't be the type of thing that I would use for making a decision whether you should have both breasts off or just one, if that's what's oncologically indicated. So I don't think I would use the cosmetic aspect of it, because the reconstructive skills of most plastic surgeons can do a very good job. And you might say there's some asymmetry, but one of our female colleagues always said that they're sisters, they're not twins. So they're never going to be identical from the beginning. So don't use that as an indicator.
Yeah, I guess the one thing to add to that would be if you're having a DIEP flap, there's only the opportunity to do that at the one time in terms of doing a bilateral DIEP. And so sometimes that does become a factor in the discussion.
Please, in the front.
We just had a question about the DIEP flap reconstruction and regarding the involvement of removing the rib. We were wondering if this is always the case or if this is depending on the case situation, and also if it has to happen, if it's on both sides of
So that's an excellent question. So we remove a portion of the cartilage in the rib, and that is because the vessels that we have to connect to are actually located under that piece of rib. So if we are doing reconstruction on both sides using a DIEP flap, yes, we would have to do it on both sides. Now, there are other vessels that we can potentially use instead of those vessels under the rib, and those are vessels that are located along the axilla. Those vessels are typically smaller. So the standard of care, and typically what we do in the case of a DIEP reconstruction, is use what we call the internal mammary vessels. And that requires removing about a 1 centimeter piece of rib. So you don't tend to miss that rib. It's cartilage, and you don't miss it. And it doesn't grow back, if that's a question. So definitely doesn't come back.
Before you all get up, let me ask you a question. Could you each comment on, in your reconstructive journey or your aesthetic flap closure journey, from a dealing with the reconstruction, the choices associated with that, what was the biggest challenge that you felt that you needed to deal with, and how did you overcome that? Or was there a barrier or a roadblock or a problem or something that was a challenge for you?
For me, the biggest challenge was deciding whether I wanted to do a nipple sparing or a skin sparing. And after meeting with the plastic surgeon and having a lengthy discussion back and forth and him giving me all my options, the decision became quite easy to make to do a skin sparing as opposed to the nipple sparing. There wasn't much roadblocks for me. The process was very smooth from start to finish. Even the nipple reconstruction was done 4 months later. And again, that was a very smooth process. So not a lot of barriers. Just making that initial decision was the hardest piece.
Yeah, I would say the same, that the initial decision, being able to do an immediate reconstruction, having that as an option, I think, was a swaying factor for me for sure. And also the method presented in terms of it was nipple sparing, using that alloderm skin graft and the fat, that I didn't have to have another surgery on another part of me. Again, I keep using the word appealing, but that was very appealing for me, and helped me make that decision to have a reconstruction.
I think for me, especially with the decision to go flat, I came to that decision quite quickly. I even raised it with my surgeon on my very first meeting. And at that point, we didn't know whether I used to say, was I going to wake up with new boobs, little boobs, or no boobs? And I ended up with the no boobs. That was just the only choice that was available to me. So I think my concern was really, how would I emotionally deal with the loss of breasts and what that might look like. And so I did a lot of visualization. The Flatty community is very active and very joyful, actually. And they like to wander around without their tops on in woods and beaches. And so connecting with those individuals and also just visualizing. There was a young woman on YouTube, and I watched her video several times, just becoming more accustomed to what I was going to see. And so when I had my big unveiling in the bathroom, it was weirdest selfie ever. I had a couple of friends that were gathered around taking pictures. And I was more impressed with my surgeon's work than I was worried about the loss of breasts. And so now, quite honestly, I have to go back and take a look at, I don't even remember what I looked like with my D cups. So there's no mourning, really. I'm quite happy.
Thank you. Aisha?
So a question that's come up that's gotten a lot of thumbs up, so people are very curious about the answer, is what are the pros and cons of under versus over pec implants?
Okay, Monica, do you want to start with that?
Sure. So it depends a little bit on the patient's anatomy and how they look. So in terms of, let's talk about over the muscle. So over the muscle, probably one of the biggest benefits is the implant is not in an area, it's not going to disturb the pectoralis muscle. So you won't get that complication that we talked about called animation deformity. When you activate your pec muscle, the implant won't migrate, won't move in any way. The biggest con of going above the muscle is that it can potentially have a bit more visibility. So the difference of having an implant being used for reconstruction versus, say, a person who's having an implant for augmentation purposes is after a mastectomy, you don't really have any breast tissue left. And so you don't have very much soft tissue coverage of the implant, leading thereby to having increased visibility of the implant, like actually seeing the edges of the implant or rippling the edges of the implant showing through, or other contour issues. And so going under the muscle does provide a little bit more coverage of the superior part, so the part that might show and close, cleavage, etc. However, you do have something that's under the muscle that's not normally there. And so you may have the issue of animation deformity, you may have a little bit more lateral displacement of the implant, and those are the main considerations. But of course, every patient is different.
Just also, if there's any chance of having radiation, we would go under the muscle, just because of the radiation. Even though it's much more sophisticated now than it used to be, it still can cause what we call capsular contraction around the implant. So the radiated breast tends to be a bit smaller and a bit higher. So in that case, we prefer it to go under the muscle if there's any chance of that.
I think there was a question there, yes.
So I might be a little bit of a unicorn in the room, so I do realize that I'm probably down at the very, very bottom of the list, but I had to have a double mastectomy. I did not have a choice. I had advanced cancer. I had to have a second surgery to have axillary node dissection. I had neoadjuvant chemotherapy double mastectomy, and I just completed 25 rounds of radiation. I've previously had an abdominoplasty, so a DIEP flap is not an option for me. Immediate reconstruction was not an option for me because, as you said, is the radiation. I'm running out of options. I've visited 2 plastic surgeons, and no one's really interested in doing anything with me because I want an aesthetic flap closure, but I'm extremely concave because they had to take out so much tissue. I just don't feel like there's a place for me in reconstruction right now. I just want a nicer flat chest. And I think that that should be an option for me. And it doesn't seem to be.
I'm sorry, you're waving back there to get my attention.
Great. Anybody else in the room?
Back in 2014, I got diagnosed with breast cancer. I had mastectomy, I had radiation, and chemo. And because of radiation, I was told that I could not have an implant. However, science saves the world. So there's the stem cells. I got stem cell, I forget what it's called. Stem cell.
Well, you've got fat transferring, which includes stem cells that helps to rejuvenate the tissue.
So I got fat transfer from my body to my breast, and that you wouldn't believe how that rejuvenates the skin. And I did get implants.
So maybe a bit along those lines, and it's very difficult to talk about unique specific cases, you know, we're talking in generalities, but there's almost always hope and options. So don't be too down, and you're probably not a unicorn in this, you just feel that way. And most of the time there is choice. It doesn't mean it's always a good choice, and sometimes the best choice is nothing. And that's okay. You just have to know get the information, make a decision, and come to be comfortable with that. But most of the time today, there's something that can be offered. For an otherwise healthy individual, there are choices. There's a lot of things that can be done with fat grafting. I think all the experts on the panel today would tell you 15, 20 years ago, radiation and implants, they were taboo. They didn't mix. We just stayed away from it. Today, we do implant-based reconstruction on many women who either have had or are going to have radiation and get excellent results. The technology of implants have changed. The acellular dermal matrix that you heard talked about today has helped us a great deal. Fat grafting has changed. The quality of mastectomies have changed. So many things have changed, allowed us to do things that we couldn't do previously. So just from the description, it sounds to me like there's some things that could be offered to you. Yeah. Please.
Hi. So for me, I'm more interested in the DIEP flap procedure. I've done a lot of research and I'm on the wait list right now, so I'm just waiting for a phone call. And my question to you is, I've heard a lot about like phase 1, phase 2, phase 3, and there's a lot of confusion. Like, is it possible to do just the initial DIEP flap surgery and then not have to go through another phase 2? Because I don't want to go through surgery again. I've had mastectomy, and I'm going to do this surgery. So is there a possibility to just have like the one and not have to go through phase 2 and 3 and so on?
Yeah, sure. I mean, I've heard these phase 1, phase 2, phase 3s, but they're not from us. I don't know where these come from. Having said that, I think what they mean is that there are some cases where you might require some revision surgery. For example, if you're doing a DIEP only on one side, you might require a balancing procedure. Or maybe phase 3 or phase 2 can be a nipple reconstruction, for example. So absolutely, you can achieve the reconstruction in one stage. Depending, and often if you're having bilateral reconstruction, that's definitely a possibility. And then some of these phases that we talk about don't necessarily require a general anesthetic. So a nipple reconstruction can be done in the clinic, as Dr. Semple mentioned, or you might not even want a nipple reconstruction, or if you want a 3D tattoo, that's also an option as well. So that does not require further surgeries.
You know, it's an interesting concept, but I've always told my patients that breast reconstruction should be looked at as being like a work in progress. And the reality is, I don't think any of us have seen any of our breast reconstructions where you wouldn't look at it and say, there's something further that you could do. There's something more we could do to change it or make it better. The question is, when is enough enough? You know, when is it close enough? You know, everyone wants to strive for perfection, but as Dr. Semple said, they're not supposed to be exactly the same. It's okay to be a little bit different. So sometimes embracing that's important. So the idea of, you know, the patient gets to drive that bus. When are you comfortable? If you're comfortable, you're done. If you're not comfortable, talk about what else might be able to be done. You know, there's no rule book necessarily for that. Please.
Hi, thank you. I have a two-part question, please. The first is, I've heard DIEP now described like as a tummy tuck on several occasions. So I would like to know how accurate that really is. And the second part of my question is, could you provide some advice for steps a patient can take if they've developed a painful abdominal bulge following DIEP and are really provided with no options for resolution despite ongoing self-advocacy, especially in the case of a doctor not really having the view that you just said about a work in progress. Can you please provide some advice?
Yeah, we'll try to do that.
So with regards to it being like a tummy tuck, it is not exactly like a tummy tuck. So a tummy tuck implies that all that skin and tissue and fat that we have is actually removed and discarded. A DIEP flap, you're actually looking for those small vessels that supply that skin and that fat, and you're actually following them within the muscle. So in some cases, you have to take some of that muscle if those vessels are very, very small. And in some cases, you don't have to take any muscle. However, you have to dissect within the muscle in order to take it. So it's not entirely like a tummy tuck. In the case of a DIEP flap, we have to open up the fascia that is above the muscle, and then we have to close that fascia as well later on. So it is not exactly like a tummy tuck. However, the scars can look like a tummy tuck, okay? With regards to a painful bulge, so absolutely, or a bulge, that can definitely happen. The risks of that are about between 6 to 10% of that happening. And then it really depends whether it's a bulge or a hernia, but there are definitely some techniques that are available in order to help with that and fix that and strengthen the abdominal wall.
So we're running a bit short on time, but I'd like to get to at least another one or two online questions, Aisha.
Yes, another question that we have online is, how might reconstruction affect detection of any recurrences?
Yeah, thank you for asking that. Dr. Sill, you want to start with that?
Yeah, sure. So having immediate or delayed reconstruction is absolutely safe from a cancer perspective. There's no worse outcome based on the reconstruction. And it depends what kind of reconstruction in terms of what is needed for ongoing screening. So if a woman has had mastectomies on both sides, then the surveillance really is clinical exam, not any breast imaging on a routine basis. But if there is breast tissue, so if you've had a mastectomy on one side and the other native breast remains, then based on age risk factors, yearly mammogram is needed, and some women may need adjunctive screening with either ultrasound or MRI. And any kind of surgery that may be used for balancing for the other breast, it does not impede evaluation with the imaging that we have, especially if you go to a high volume center where they're very used to imaging breasts that have had surgery.
And one last question.
So several people have asked about different types of breast surgery years after the cancer and initial treatment. So for example, they've had implants and might now want to remove an implant. They might want to remove a healthy breast to obtain symmetry, or even have surgery to try and obtain more symmetry to match the other side. So would these procedures be covered by OHIP or other provincial health insurance plans, and who should they be seeing for these types of surgeries?
Dr. Semple, you want to tackle that?
That's about 10 questions right there. Yeah, so you're talking about I think the symmetry, like having the other breast off, if it doesn't need to come off, is a whole different area and a longer discussion. And I think that would be something that you would want to take up with the oncological surgeon in terms of the risk around that. And even though we're surgeons that we like operating, we like to be reluctant surgeons, so we don't like to operate if we don't need to operate from that point of view. I think that there's always opportunities for touching things up and making things better. And again, as Dr. Brown was saying, it takes, as time goes along, there can be the things settle, things change. It could be a bit of capsular contracture. There's all sorts of different things that could be minor adjustments and refinements to improve things. And in terms of the last question as whether or not it's covered by OHIP, it's sort of a gray area. If it's a major issue and there's an OHIP code for that, yes, sometimes, but sometimes there's no code for it. So if there's no OHIP code, then it becomes there's usually a charge associated with that, and I wouldn't even guess what that might be, because there's often an anesthetic fee and a hospital fee associated with that. And even something like fat grafting, there's no OHIP fee for that. There's no OHIP code for that. And so most surgeons try to work that into a type of OHIP coverage type of thing, but it's not always there. And if there's certain specific requests suddenly fall outside that area that's going to be covered by OHIP, so it would be cosmetic.
So we need to move on with the rest of the program with the show and tell lounge. So Elaine will come up to discuss that. I want to just thank our experts, and I also wanted to suggest that we probably didn't get to many of the questions, but I know the experts will be here through the next little while this evening, at least many of us will be, and so if anyone wants to come up and ask any questions outside or down here afterwards, please feel welcome to do so. Thank you, Elaine.